Hello, everybody. My name is Dana Acciavatti. I'm the Deputy Director of Digital Health at IntraHealth, and together with my colleague, Dr. Amy Finnegan, who is the Deputy Director of Data Science, we'll be speaking with you about health worker registries and human resource information systems within the context of OpenHIE. So IntraHealth International is a global health nonprofit that has worked in over 100 countries since 1979. And we partner with governments and local collaborators to improve the performance of health workers and strengthen the systems in which they work so that everyone everywhere has a health care they need to thrive. At IntraHealth, our mission is centered around health workers. Health systems can only function with health workers, and improving health service coverage is dependent on their availability, accessibility, acceptability, and quality. And as I'm sure many of you are familiar with, OpenHIE is a community of people building an open framework to support nations as they develop health information exchanges to improve patient care, public health, and management of health resources. We also wanted to touch for just a little bit on the importance of digital public infrastructure, or DPIs, which are intended to perform a basic function at scale in a way that others can build upon, so a building block approach. DPI should be guaranteed by public institutions to be inclusive, foundational, interoperable, and publicly accountable. A DPI approach for health can best support an ecosystem of interoperable digital health applications to achieve the inclusive, person-centric, equitable outcomes we strive for. So IntraHealth works in building essential DPIs, including the Health Worker Registry, Client Registry, and Facility Registry. And the OpenHIE framework shows how different health information systems can work together to form a country's e-health architecture. Registry services, as we just touched on in the DPI slide, are health exchange components that are designed to support with data that is used by other health exchange components. And today we'll be looking at the health worker registry component. And our approach is to use a minimum data set of health worker data that can be pulled from multiple information systems, and which then merges that data into a registry of health workers that serves as a single source of truth. So we're going to share an overview of IRIS, which is used both as a health worker registry, pulling data in from multiple systems, and as a human resource information system, which is used by health information managers. IRIS is IntraHealth's free open source health workforce information system software that helps countries around the world track and manage their health workforce data to improve access to services. Countries use IRIS to capture and maintain high quality information for health workforce planning, management, certification, and training. During the height of the COVID-19 pandemic, the governments of Mali and Kenya partnered with IntraHealth to mobilize and prepare health workers rapidly. Together, we used data from IRIS as well as other national information systems to model when and where outbreaks would be worst. Initially developed in 2005 with national stakeholders with support from USAID and numerous other donors throughout the world, or throughout that time. IRIS has been used in more than 30 countries to manage well over 1 million health worker records. IntraHealth is currently implementing projects in Ethiopia, Togo, Chad, Namibia, and Madagascar. In Chad, we're supporting health workers that are working with refugees at the Sudanese border. And in Madagascar and Namibia, we are developing a community health worker registry. So we wanted to just touch on an IRIS user story. And this example is from a perspective of a healthcare manager who wants to be able to easily register new health workers, including their personal information, qualifications, position information, and contact details in order to maintain up-to-date information on all health workers across the country. So the registry streamlines HR processes, including identifying job vacancies, tracking promotions and transfers, managing individual performance, and looking at skills and distribution to ensure the necessary staff are available to provide quality care. And training managers can also track training and certifications of each health worker to identify gaps in training and schedule refresher courses as needed. So here's an example of a health worker record. It tracks individual information on health workers and community health workers, which can include demographic and contact information, education, so both pre-service, in-service, and continuing professional development, job history, information on the current position in the facility where they are posted. It also can manage more complex workflows like managing performance goals and performance evaluations. And this is an example of what a dashboard can look like. So these dashboards are interactive and user customizable. So no developer is needed to tailor these once they're set up. And the display can combine national aggregate data, and you have the ability to drill down to the facility level in any of these individual graphs. You can also look across specific time periods. And the charts that are shown here display age distribution that can be used for retirement planning, gender views across the workforce, as well as position and job distribution. And the dashboards are tailored to display key information desired by each country. Okay, so we wanted to get into just a couple of country examples. And so the first one is on time and attendance in Uganda. Here, this is just an example of how we were able to work with the government of Uganda to reduce absenteeism. We introduced biometric attendance tracking through facility-based machines and smartphones starting in January of 2016. And data was tracked and analyzed in IRIS monthly by payroll managers, facility heads, district health officers, and chief administrative officers to inform sanctions and the removal of ghost workers. And this resulted in a reduction in health worker absenteeism from 50% in 2015 to 8% in 2019. Now, another example from Uganda is working with the medical councils. And this graph shows the uptake in annual license renewals in Uganda from the point in which IRIS was introduced. The council was able to see data on who is registered and licensed and able to track qualifications and continuing professional development credits. And then this also helped them send reminders to pay fees and follow up with practitioners who had not paid. And our final country example is on eliminating ghost workers in DRC. In 2017, the Democratic Republic of Congo analyzed IRIS data in combination with payroll data in 2 provinces. Over a quarter of health workers receiving salaries were revealed to be ghost workers. And about half of health workers in those provinces were receiving risk allowances instead of salaries due to scarce resources. So 42% of those were ghost workers. So the ministry was able to rapidly reallocate nearly $2 million away from ghost workers to cover 781 salaries and an additional 2,613 risk allowances for nurses and midwives who were not previously compensated or who were being undercompensated. And I'll turn it over to my colleague, Dr. Amy Finnegan.
Thanks, Dana. So I'm going to talk about some of the data science approaches that we've been developing that you can apply whether you have IRIS or not, as long as you have data on your health workforce. Yeah, so I'm going to talk about flight risk analysis, global health emergency corps, and dynamic health worker redistribution. So this is the first example of what you can do when you have basic data on your health workforce is that you can track factors that lead to absenteeism and retention so that you can target those factors. So the user story for flight risk analysis is, as a district health officer, I'm responsible for ensuring staffing levels at the health facilities in my jurisdiction. However, I know that some staff maybe become burned out and leave the workforce. I want to be able to identify which facilities have the highest proportion of health providers at risk of burnout so I can intervene at those sites specifically to ensure continuity of care. This is a kind of made up example using fake data, but it kind of illustrates the idea that we're talking about. So we can use factors in IRIS like the age of the health worker, whether they are compensated, the same level as their peers, given their training and experience? How long has it been since their last promotion? Are they getting paid on time? What is their education? What is the environment they're working in? So what are the factors, the similar factors of their peers at those facilities? And we can use those factors to predict turnover in the workforce. We can show where the most urgent turnover risk is. So each of these little pie charts, for example, show that at Pioneers Hospital, more than 50% of the health workers at that facility have a high turnover risk. Whereas in Bali General Clinic, more than half of those health workers have a low turnover risk. So we can help direct our technical advisors to minimize the risk of turnover and burnout at those facilities. So I do like to say that with data science, a lot of the approaches we can employ can tell you where to go, but you still need technical advisors to tell you what to do when you get there. So that's one of the kind of benefits of working with IntraHealth, is that we can both tell you where to go and then rally our health workforce advisors to provide support on how to address these challenges. The next example I'm going to talk about is what we're calling the Global Health Emergency Core, or GECKO. It's how you can use IRIS and health workforce data for emergency response. So emergency response planner, I struggle to know which employees are trained in emergency response, where they're located, how quickly I can deploy them during an emergency when every minute of delayed response counts. I want a system that allows me to see where my emergency response workers are in their current training, so I can ensure that I can prepare them for emergencies and deploy them when needed. So with a few additional features added onto IRIS or your health workforce planning system, you can select a high-risk country or a region within that country and get some basic data on the risk category, risk status, and a population percentage affected. Or if you know that there is an outbreak, you could click on that geographic location in your interface, and then it would pull up a list of the health workers, or in this case, emergency response teams that have already been created in IRIS, tell you the number of staff available, how close they are to that outbreak or crisis, the travel time, and their available skills and training. With some additional features, you could build your emergency response team. So you could have a list of the health workers and their training. And once you select them, you start to build the team to respond to that outbreak using some connections to APIs and some budget information. We could pull in the travel time and costs to mobilize those teams. With additional data collection and some additional features on top of IRIS, we're really excited about being able to build some of these global health emergency cores. The last example is on dynamic redistribution of the health workforce. So this district health officer is responsible for achieving targets for HIV viral load suppression and retention to end the HIV epidemic in their district. He knows that he has too many health workers in some places and not enough in others, and they want to know how to redistribute the health workforce that they do have today to maximize retention of HIV clients in order to ensure viral load suppression. In this example, in Uganda, we were able to take that information on the health workers, where they were distributed, and then estimate what the optimal ratio of lay workers to clients on treatment would be. In this case, it was 50, but the number may vary based on the health outcome you're trying to maximize. So we can estimate how to maximize retention, and then each of these sites is labeled red, green, or yellow based on the health worker ratio at that facility. So if you've got a red facility next to a number of green facilities, you could redistribute the health workforce or the workload between those sites so that you could maximize retention without having to move health workers very far. And you could apply this to other outcomes as well, like the number of deliveries or family planning delivered, or any outcome you were interested in. So this is our last slide talking about some of our health workforce analytics services. So if you want to work with us, you could invite us to do a free readiness assessment to check if you have the necessary data to work on any of these approaches. Dana talked about IRIS and headcount planning. We can set up headcount planning dashboards. Using IRIS data, we can do the flight risk analysis and ratio optimization. And IRIS can also be used to submit National Health Workforce Accounts reports. It can also be, the data can be reformatted to do the PEPFAR RH inventory reporting as well. If you want to do some additional analysis with IRIS, we can help launch employee engagement surveys and store that in IRIS so you can see more about the turnover and burnout risk in your workforce. We can train on health workforce analytics. We can provide remote technical assistance, and we can also travel to provide in-country training. So I hope that was a fast but exciting journey through health workforce analytics that we can offer using health workforce registries and repurposing them for advanced analytics. So you can contact Dana or myself if you want more information, and we're happy to stay on and answer questions, and we look forward to the reactions from the other speakers. Thank you.
Good evening to everyone. Thank you for this opportunity to react to the really very good presentation that we just heard. Speaking from the USAID HRH 2030 experience that we had a number of years ago, and my work with DOH, I would say that the IRIS is very exciting and something that countries in the low medium income countries like the Philippines would very much appreciate, and it would be very useful. In HRH 2030, we did try to build interoperable systems working on what the country had, but it was too hard, and we did not finish really setting up the data system. Well, how will it help countries like the Philippines? For one, the Philippines is really looking forward to a registry of health workers like this. We have our Universal Healthcare Act of 2018 that really specified that, and the law provides for the setup of a health worker registry, both for information and for policymakers and program managers to act on. The country also looks forward to coming up with a health worker pool that will be based on this registry. So I think it's useful, very feasible for both internal and external information. But there are challenges. But I'd like to show 3 slides very quickly to explain what we will be saying in terms of challenges and how we can use the IRIS for applications. So Chap, can we put on the slides, please? Okay. So in our analysis, in our health labor market analysis that we did in 2019 to 2020, we saw that the Philippines produces a lot of health workers, and we're seen the world over globally as a major producer of health workers, especially nurses. And so we are identified internationally as an ethical source of health workers, which is very unfortunate because now we are in dire shortage because of this misinformation. So we have a huge number of enrollees in this data that we're using, 3.5 million, but 2 out of 10 students graduate only, and so we don't really turn all these enrollees into graduates, much less the health workers who would really provide the services. We have about 720,000 qualified health workers, but 56% of these go to the private sector and only 13% go to the public sector. But look at this. There's 31% out of the labor force, and we do not know where they are or what they are doing. So in terms of vacancies, we have 4 out of 10 vacancies. that are in private hospitals, while the rest are from the private hospitals, totaling to about 12,000 in vacancies. So the if you will look at the outcomes here, we have a huge outflow and we do not know where they are. So there's about 12,900 jobs per year lost to migration. And we also have about 11,000 jobs per year in the BPOs where the health workers go to. So next slide. So like I was saying, next slide, please. So in terms of nurses, we are thought to have a huge surplus of licensed nurses, which is not true. Right now, we have a gap of about 126,000, or very few nurses practice in health facilities. So we want to know where they are. We think about 300,000 have migrated out, but there are about 121,000 that have unspecified practice that we'd like to get back into active health services. Next, please. And this is the last slide. So you'll see that we don't really have enough even to meet the basic SDG requirement. No? So just to show more graphically the gap and the supply, for hospitals, there's a bigger gap than the supply of health workers that we have. And even in the primary care facilities, our UHC implementation is threatened by a lack of health workers right now. There's a gap of about 11,000. But this is bigger because we actually are now analyzing the real need for health workers at the primary care level. And we're seeing this is much more because our focus in the past was mostly on tertiary care. So, so what are the challenges? Finally, no, we and Dr. Marcelo and I have been discussing this over the years, and we believe it is governance. Governance is the biggest challenge. We need champions to really push these health information systems to be designed, put up, implemented. In many meetings that we've had, what we've seen is that there is low trust among even public agencies to share data. So when Iris when the Iris speakers were saying that you just need to pull data from different different agencies, government or private agencies. This is what we at HRH 2030 envisioned, but it is not possible at this point because people do not understand why data has to be shared freely, even if we tell them. Interoperability and the technical aspects of designing and putting up a system is also a big threat right now. And so if there is an HRIS, the IRIS, that is free and open source that can be adopted and the government can be helped, this will cut short the whole process. I'm very interested in the data analytics. The flight risk analysis is very useful for us, but we're also trying to find out how we can change the population to health worker ratio that is facility-based using WISN. The country is now using the NOAA system, but unfortunately, external agencies, even like WHO and ICN, sometimes misread our data. And that's why, except when we tell them during meetings that we are ourselves in need of nurses and other health workers, then when we show them our data, that's when they realize that the information out there is wrong. So I laud and appreciate the IRIS and what IntraHealth is doing to develop this, and we hope that one day we can bring this to the Philippines. Thank you very much.
Thank you, Dr. Lin. Now we'll hear from Wilson from Kenya.
Good morning, good afternoon, and good evening, everyone. I hope you're doing well. Thank you Thank you, Dana and Dr. Amy, for the good presentation and good work. For me, I'm an HIS developer, so I do not have so much experience as a doctor when it comes to dissemination of services to to when it comes to health and medical care. But I do have experience with working with NGOs. I currently work with an non-governmental organization that does HIV, both in terms of care and prevention. So I develop systems for them, and the biggest reaction I can say the H-risk can help is when redistributing workforce. Most of the data that we collect is on the clients, it's on the patient side. We do a lot of analytics on them, but the directive in our country is that the HIV program is a one-way pool. We all pull in the same direction, share data, but some of the areas that we are covering experience laggages when it comes to dissemination of services, and this is majorly based on the distribution of the workforce. So I think the analytics that the H-risk provides is very crucial to this, because as we pull in the same direction, we have to also to ensure that there is continuity of services, continuity of training, continuity of the healthcare workers. We have to ensure that we get the best out of everyone, and I think this will help when it's implemented in our country. For me, I'll say it's a well-done system. It aligns perfectly with the goals of healthcare and medicine.
All right, sorry, we lost you for a moment there, Sir Wilson. In the meantime, maybe we can proceed with the questions. We have a question here from Dr. Adebawo. Do you use any middleware for the analytics, or does Iris have it built in?
Sure, thanks for that question. I think my answer, I talked about how headcount planning is built into Iris. So looking at the age distribution, education, training, all of that can be done in Iris. The analytics that we did, if it requires data beyond the health workforce, like the ratio optimization, we extracted that data from Iris and the country's data PEPFAR reporting system, and then did the analytics in R, and the visualizations were in the R leaflet package, which I think uses D3. But any of these packages could be used. Our preferences on my team, our preferences for R. You could do it in Python. Some of it you could do in Power BI, but not all of it. I typically find R to be the best tool to use.
Thank you, Dr. Amy. We have another question in the chat. It reads, in terms of governance in other countries, who is the owner of the HRH registry? How do they manage key partners who refuse to share HRH data?
All right, this is Dana. I can speak to that. So typically Iris is owned by the HR department at the Ministry of Health. There may also be other collaborators, such as like a medical council or nursing council. Sometimes it's an FBO that wants to do the workforce planning, but most often it's the HR department at the Ministry of Health. And what we have tended to do is to get a technical working group together and have it be cross-sectoral. And so that you're working with stakeholders at the Ministry of Health, different departments, but also perhaps the Ministry of Finance, if there's interest in sharing information to the Ministry of Finance in other sectors. And we also try to work at subnational levels. And so that there is a group that's meeting regularly to look at the data and, talk about how that impacts the healthcare delivery in their area. So, and yes, I mean, there can definitely be some challenges with sharing information. The system can do it. It's built on using the FHIR standard. And so it's very easy to do data exchange, and we have an API, but yes, the governance is typically the piece of the piece of the work that takes the longest time. And you have to make sure that you're meeting those stakeholder needs. Additionally, I believe one of the speakers was saying that sometimes it's hard to get data shared, and we found that to be true with the Ministry of Finance and Payroll. They typically do not want to share payroll data for obvious reasons. But what we've done in those circumstances is shared the IRIS data with them and allowed them to go through the different list and, and clean up the payroll system that way.
Thank you, Dana. There's another question here. So are there templates for data sharing policies and other policies using IRIS from other countries that can be shared?
We have used some standard templates, but typically, we would work in country and figure out exactly, what those workflows need to be. So I don't think that we have any. I think we have some very bare bones ones available on our implementation toolkit.
Thank you, Dana. We have some questions in the Q&A box as well. So this one is from Dr. Aminul. What is the data quality status among countries using IRIS currently? Accuracy, completeness, timeliness, consistency, and validity of the data.
So IRIS does have some built-in tools that can run. We have a script that it can run, so it can check on data completeness and then flag the records that are missing certain key pieces of information. I don't have the stats on with me now on the different countries, but that's something that is part of like the system where they're supposed to be running that regularly as part of their standard operating procedures. And then, filling in the data as needed. And data collection is also certainly another piece that can take a lot of time. So it really depends on this, the quality of the data when you're getting started, and and having to go through that process to do the data validation at the beginning, and then making sure that you have very clear standard operating procedures and that it's very clear in people's job descriptions. So as the frequency that they're updating their records and maintaining the data.
Thanks, Dana. We have another question in the Q&A box. It's from Dr. Julio Tualifo. Is your payroll system linked to IRIS? How did you do the analytics to compare IRIS data with the payroll? Is there a reliable primary key that you use to triangulate the data?
So typically we have not linked the payroll system. Because the Ministry of Finance is not something that they've been wanting to do. So it's more of like a one-way direction where we share the data with the Ministry of Finance, and then they go through the process of doing the data cleaning. But we've gone through to do the data cleaning in IRIS, like it's varied in different places. Like you can ask for, updated records from, the individual facilities or do a survey. We've also sent data collectors out to facilities. In some cases for payroll cleanup, we've asked the health workers to come in and report and during a certain time period and show that they are, in fact, an actual person. And then they've had a certain window with which to report. And if they didn't report, then they were, given notification that if they had a second opportunity. And then if not, then they've been removed from the payroll system. And so again, that was us, not linking the data, but providing updated data to the Ministry of Finance.
Oh, sorry, I should have put my hand up and then say that IntraHealth developed a tool called OpenCR that is a client registry, which is also part of OpenHIE, but it could be used to link databases of health workers across sites or different lists that you have. I dropped a link in the Q&A.
Oh, thank you, Amy. Yes, it can do the deduplication of records for people across multiple systems or multiple lists.
Yes, we have a new question here from Dr. Alvin. He's asking, how many IT people do you estimate are needed to maintain an IRIS for 110 million people?
Gosh, that's a good question. Let me think. So, normally we have like a central team at the Ministry of Health that is maintaining, sort of the aggregate information, and you have different people playing different roles. So you have the HR department, and then you have like the policy and planning department, and there's usually just a few, key people there that are managing the system. And then there's also depending on which levels you want to go down to. So we typically have a few, like maybe let's say two or three people at like the regional health offices. as well as like the regional referral hospitals that would use the system and be maintaining and updating data. And then we typically the district, the next level down, the district health offices would also be updating the system. You can go down a level further, like in Ethiopia, they're going down to the WAREDA level and having the data entered there. But you really only need like a person or two, you know, per facility to update the data. And then again, you do want, if you can have those technical working groups that are bringing in people from, you know, the different other different stakeholders within those levels to look at the data together and see how it affects, you know, the different activities that they're doing. That's an ideal thing. But it doesn't need like a large number of people to maintain. You just need to have a couple of people that are doing that, you know, that data maintenance and updates. And as the health worker it moves through their cycle and gets promoted or transferred or retires.
Yeah, I think that sounds like a great opportunity to use a wizard to understand how many IT people you need to maintain a system. I don't think anyone's ever done that, but if they did, if someone knows about it, would love to hear about it. I'm also thinking about the people that you need to actually maintain the health workforce planning and using the IRIS data. So we don't know a number for that, but we do have 2 maturity models that we developed in our HRH Kenya project that look at the maturity of the HRH unit and their ability to employ data and to use it in their decision making, and then also the maturity of data use in the IRIS systems at the county level. And we have a publication or a preprint showing that improving maturity was associated with reduced absenteeism in Kenya.
Cha, do we have more questions? I think there's one more in the...
Yes, I think this is a new question. It's from Dr. Julio as well. Is the system in a specific data center or on the cloud, and who is responsible for the security issues?
It could be either in the cloud or in a local data warehouse at the ministry, depending on the, you know, whichever option that the country wants to go in. We will work with the ministries if it's going to be in the ministry's IT and working with that team. We will work with them on the different data security that they would need. And if it's in the cloud, then that's usually handled by the cloud, the vendor themselves.
Thank you, Dana and Dr. Amy. I think that's the last question so far, Dr. Alvin.
So I have more actually, Amy and Dana. Let's pretend we got lucky tonight and I'm the Minister of Health of a country and I'm impressed. I think this is what we need. What's the time for, and then I have your email addresses. I email you. I tell you, let's do this. What would be the sequence of activities? What would be the time frame from the time I sent you the email to the time the system is up and we're now starting to populate the database? Because we're not writing software anymore, right? This is already written up open source software. So it's essentially my understanding, just an agreement between the government and IRIS to install, configure, localize. And how long will that take such that when we say from the email of the ministry to go live, what do you think is the time frame? Of course, the initial countries took some time because of the learning curve, but I'm sure you've developed a lot of knowledge and capabilities already on installation and configuration. 3 months? 1 month?
Yeah,
What would be 6 months?
So of course it depends. It depends on
Right.
the country. It depends on I think the maturity of the governance structures that may or may not be in place. It also depends on whether there's existing data or not. But as far as like customizing the actual system, like typically what we like to do is come in and do a requirements gathering workshop where we bring different stakeholders together and we discuss the different needs. Sometimes it takes a while to figure out the hosting. So we typically will build in the cloud and then figure out working with the ministry's IT team, and figure out like the longer term plan for hosting. And that can vary by country. But once we have the requirements, it doesn't take very long. There's usually not anything that's too complicated or outside of what we have already been working with. So I would just say maybe like a couple of months to do like a month, to kind of do some initial conversations, do the requirements gathering, and then build the system per those requirements. And then we like to do like a user acceptance testing where we then, let the stakeholders that were in those workshops and others, test the system and make sure that it's kind of everything is set up the way that they want. And then we typically would like to, there's some small changes that would need to be made following the user acceptance testing. So that, that can be done in a matter of months.
Yes.
And we've been working in Chad since let's see, mid-January, and we've just turned the system over to them. They did their initial testing, and now they're going to use it for the next couple of months. And then we'll be going back to do like a larger training after that time, because then we also want to we typically will do a training of trainers. In this case, they had the data ready. So there wasn't a large data collection exercise that was needed, but that can also vary, right? Is there already good data at the central level? Do we need to send out data collectors to how many sites? So I mean that process can depend, and depending on the scale. So, and obviously countries that have a large number of health workers, that takes longer. And then sometimes if we support the cascade trainings and the national rollout, then we can be involved for years. If we're just doing the initial implementation, I would say, like 9 months maybe would be like a good time. We also like to have a few months where we can provide the support and maintenance as the system is being scaled, because there's always small changes that come up where somebody will they'll want a new report. I didn't show in the slides. There's also tabular reports that we can set up as well. And so if somebody wants a new report, or they realize they want some changes and tweaks here and there to way that the information is collected, then we like to remain available to do that. So that can extend it to like a year, just so we make sure we have those few months. So yeah, but that's plenty of time. So it can depend. Oh, and I see Amy's raised her hand. She also wants
Amy?
to.
Yeah, I just wanted to chime in on acquisition of funding as well. So there are a couple global projects that countries can tap into, like Digital Square could fund an IRIS implementation, or CHISU, and then the new integrated health systems strengthening activity that's going to be a $320 million global project over the next 5 years also offers an opportunity to strengthen human resources information systems.
Thank you. And I mean, what Dana mentioned about talking to the stakeholders, data gathering, requirements gathering are all typical standard software deployment processes. But definitely, can we say, hands down, an IRIS team would beat another team developing the software from scratch, right? I mean, because you already have the package, it's been field tested, it's been refined from the experience of 30 countries. And then there's another team who's starting from scratch. Again, still talking to the stakeholders, data gathering, but then after all of that, they still have to write the software.
Yes.
You'll beat them for sure, because you already have the software ready to
Yes.
run after the configuration. So
And
my point
them.
is my point is the open source software and the availability of a mature package hands down beats software that still needs to be written out.
Yes, and we are already done a lot of the interoperability work with other global goods. So that's already in place. And again, we're using the FHIR standards, and so it makes it very easy to do data exchange with any other system that it's using that standard.
Is there a sandbox, like a demo that we can start using and then like so that they can get their hands and heads around an iris?
Yes, there is. It's on our website. When it was down recently. There was something going on with the server that's hosted by AWS, and so we're figuring that out. But it's at I'll just put the website here in the chat, www.iris.org. And there's also that's where you can find our implementation toolkit.
Yeah, well, Dana's doing that. I'll also add that, we've developed the software, we can help customize it, but if there's a country-led approach where they want to lead the convergence workshops and they want to lead the requirements gathering, we can also step in as the software developers and then help the government IT developers, or however they want to do it, be able to configure the system themselves with minimal support from us.
Okay. And there's the Dana answered the question about Docker. Yes, there is info on Docker. Great.
Yep, now, let me get that link and I can put that in the chat as well.
Thank you. Wilson, any more last words? Ma'am Lynn?
Dr. Alvin, I think Sir Wilson already left because he has another meeting.
All right. Okay. Thank you, Cha. So, last words, Dana, Amy, and then we'll have a group photo.
Just thank you all for your time and attention and all the really great questions.
Thank you. I was also really impressed by the video at the beginning. I wanted to say that was so cool to see what AHEN has done. So thank you for having us today. And we hope to hear from you soon, some of you soon, if you want to be able to use IRIS and health workforce analytics.
All right. Thank you, everyone. Thank you, Dana. Thank you, Amy.
Thank you, everyone.
Thank you,
Thank you so much.
Thank you, guys. See you next time. Bye.
Thank you. Bye.